MaineHealth Lincoln Hospital Watson building. Beautiful, crisp winter morning in December. I can't even believe to say that it's December 5th already, but I appreciate that you're all here. And so you know, we do thank LCTV for being here, as always, with us. They're fantastic, supporting us and live streaming this meeting, as well as having it available for people to watch in the future. So thank you very much for that. If you don't know who I am Cindy Wade. I am the president here at MaineHealth Lincoln Hospital. I've been in this organization for 31 years. Hard to believe. Thank you, thank you. And I've loved every minute of it. And this is one of my favorite things to do, other than going to visit with all the care teams in their space and see how they're doing. I love to visit with the community and have an opportunity to tell you what we've got going on here locally, what's changing, what programming we have. It's very important that folks know what's happening. We're also here to answer questions for you. So if there are things that you want to know about, please let me know, or let one of the team members know. We can either chat offline, or we can add them to an agenda, because this is a meeting for all of you and for our community. So we want to make sure we're hitting the right high notes for everybody and sharing the information that's most important and valuable to you and the rest of the community. So I want to thank Julie and Sarah and Revan from our philanthropy team for always pulling this together and having some fabulous speakers today, updating on some things that are going on. You're going to hear from Jennifer Bryce. She's going to talk about memory changes, what's normal, what's not, know the signs, stay informed, and she's fantastic. We're also going to hear from our diabetes educator, Amanda Millay, and Amanda's going to talk about diabetes education, something that is very important. And then we have Melissa Brown, our fearless leader of not only Infusion Center, but also right now interim for our surgical services, which is huge in of itself. Her job, both of them are ginormous. So we're going to hear from Melissa also this morning, and she's going to talk about our Infusion Center. So, Jennifer, did you get a chance to take a breath coming in from the cold? No, we've been keeping Jennifer busy. She on the side, she's an amazing artiste. She also, so last night in this very room, we transformed it late last evening back into a community center room, but it was a little bit more festive, and we treated the leaders in our organization to some paint night with Jennifer, and we all got to paint those beautiful red trucks with a Christmas tree hanging out of the back. It was very nice to kick off our December month and have some fun with our leaders, and the hot chocolate was fabulous.
And they all did pretty well.
And yes, they were beautiful. My husband was so impressed. He goes, "You painted that?" He goes, "What's the..."
Tell them that there's a drawing underneath.
No, no, we didn't tell him. And Jennifer sent me home with a little bit of red paint because I think I put too much white on my truck, and so I wasn't happy. She goes, "Here, take some red paint home with you." So anyway, that might happen this weekend. We'll see. So, Jennifer, it's really great to have you with us. She is a speech therapist extraordinaire as well, and she's here to share some information with you. So, Jennifer.
Thank you. As Cindy said, my name is Jennifer. I'm a speech pathologist, and I work up on the hill in Van Winkle Wednesday, Thursday, and Friday. And primarily, I see adults who have had some sort of a neurological condition. Maybe they've had a stroke. Maybe they're just having trouble with their memory. Maybe they've had difficulty swallowing, anything that has to do with the brain or from here up, I usually say. I usually have some sort of a expertise in it, and especially when it comes to the brain. So I was asked to come and talk to you about normal versus abnormal. What, talking that? Oh, you can't. Oh, ooh. Oh, I'm on TV. Oh, you shouldn't have told me that. Okay. So normal versus abnormal signs of dementia. If I talk about dementia, what's the first thing that you think of? Does anybody have something come to mind? Alzheimer's, right. And so Alzheimer's is the most common type of dementia, but it's not the only type of dementia. So today when I talk about the 10 signs, we are talking about Alzheimer's, but it's also could be different types of dementia. So, and oftentimes dementia just means that you have difficulty with your thinking or your problem solving and or your communication. And that can be caused from a lot of different things than Alzheimer's. So it can be scary when you have some of these symptoms, but my message to you today is going to be assessed soon so we can figure that out and hopefully help you along the way to find things to either help medically to treat it and or compensate for it. So with that being said, we are going to move on to the next sign. Thank you for updating it, by the way. Yeah, ready. Maybe?
Oh gosh, I don't know what I'm doing.
That's okay.
Can you use the keyboard, Brennan?
No, I had to hook up into this.
It's okay. Keep showing passes. Keep going.
Oh,
Keep going and I'll read from that.
sorry, guys.
That's okay.
Put it in slide.
Yeah, that is a
slideshow mode.
slideshow. Yep.
So when we talk about normal versus abnormal aging, we are talking about all of us have trouble with our memory at some point. That's normal. And as we get older, it's normal for our processing to slow down, for our, remembering why we went into a room, maybe, remembering a grandson's name that we haven't seen for a while. That's all typical and normal and not reason for concern. It becomes concerning when it affects your every day-to-day life. And I'm just going to talk from this if I can, because I can see it on here. Bear with us. And so normal aging is when, I just give you a couple examples, but it's when it doesn't affect your ability to maintain your independence. Stay in your own home, manage your medications, your bills, your finances. And I even was in pageants when I was little. I should know this thing. Okay. It should be sharing. It should be sharing?
Yeah, stop.
Okay. So I'm just going to get closer. But when there is reason for concern is when it's consistent cognitive changes, and they're changes happening not just every now and then, but on a regular basis. That's when you become concerned. The other thing that is a big factor is that your mood changes. So maybe your husband, your wife, your father, all of a sudden they become really grumpier than you ever thought them to be. I was like, wow, that's really not their personality. That in combination with these concerns with memory also. It's not just projecting. Okay. So, again, that's why it's important to have early assessment. Hold tight, hold tight. Okay. You're still trying?
Well, yeah, but you're not presenting, so that's the.
I know,
I
I'm
think
just
I
trying. Okay.
think I see what the problem is. Hang on real quick.
It's good to have technology help. Sorry about that. They upgraded the system, and when they upgrade the system,
That's why I was having trouble earlier. Okay.
there's a little bit of delay in all of us understanding how it functions.
Yeah, sorry everyone. I thought I had it, but obviously I didn't.
Okay, so one of the first things that is a symptom when we talk about the 10 signs of dementia. Darn it.
Sorry.
Can I just put this over here so then I can be on the, maybe? No, maybe not. Okay, so I'll just hold it for this side. Technical difficulties.
How about we just give you the mic to hold? Huh?
Yay.
And then you can wander for like you.
What you don't want me to do is sing. That I will not do for you today. Okay, so we want to, one of the first symptom that you might be concerned about is whether or not you lose track of time. And wonder, it's one thing to not know the date. If you're not working every day and you don't have to clock in or write out a check every day, you're not going to necessarily know what the date is. But if you don't know that it's December or sometime when the snow might fall because there's snow outside, that's when it becomes concerning. If you say that as far as the year, maybe you don't recall that it's 2025, maybe you say 2024, not so concerning. But if you say 1973, kind of concerning. And now my thing is completely gone. Okay.
You're further along.
Yay, yay, yay.
How far along are you here?
I'll just click.
Okay.
Thank you. Okay, so we've gone through normal, when to be concerned, maintaining your independence. Okay, 10 signs of dementia. The first one, I think I said, so the first one that actually was on there was not time. Changes in the ability to problem solve or solve problems. So when we talk about executive function, that's your ability to take a problem, think about it, execute it. It could be that, the lights went out. What do? I need to think that through. I need to call CMP or I need to call my neighbor. If you can't execute that task, figure out the problem, and then come up with a plan for it, that is the first symptom. Mood changes of personality, we talked about that. Confusion with time or place, talked about that. And making poor decisions. We all do that also sometimes. It's normal for us to make poor decisions or that people won't all agree with. But what is not normal is if people make decisions that are outside of their character. For example, making a huge financial commitment and doing something that is completely unexpected. That might be a reason for concern. Or maybe they've just changed where they want to put their money, but you want to make sure they don't have any of those other symptoms that we're talking about. Challenges with their team, practicing. Okay. And again, normal memory loss that disrupts your daily life. That's the big one. And then misplacing things. Things that, sometimes you misplace a remote, you misplace your keys. That's all typical, normal memory loss. Misplacing things that you always know where they are and not being able to find them, and not being able to retrace your steps, to not be able to think, oh, where did I have that last? And then go back and look for it. That is another symptom. And this is often when people come to see me, is when they start to have trouble with their words, coming up with the words. If you are having trouble with word finding or not coming up with the right words, it does not mean that you have Alzheimer's or dementia, because it happens to me all day long. But it is when it's just kind of funky and you notice that it's happening often, and or you start to replace abnormal words, like it's something that just doesn't make sense. Visual spatial. This is one that is not so common or you don't think of, but difficulty feeling your body in space. So for this carpet, for example, when I go into facilities that are long-term care and I see a carpet like this, I get really concerned because this is visually not good for someone who has cognitive impairments. Being able to depth perception. You might start to notice that with driving, like, oh, wow, that came up quick. Or anything that has to do with where you are in space versus what you're seeing is also a symptom. This is a big one. Withdrawing from social activities or withdrawing from work. Somebody who used to be very active in the community and now is just staying home, doesn't want to go out. I will say, though, this is a big one for folks who have anxiety and depression. And that is, I've had a lot of people lately in my office who are coming for a cognitive eval who are just depressed. Life is kind of sad and scary right now in a lot of ways, and oftentimes it's the depression that needs to be treated and not necessarily a dementia or a cognitive impairment. And I'm able to help kind of figure that out by talking to their doctor and getting them what they need, but it is also a symptom of Alzheimer's and other dementias. Withdrawing from social things. Am I way off? Am I doing okay? Okay. Oh, shoot, what did I, we didn't have 10 points there, did we? Let me go back. Are you counting for me? Thank you. Oh, okay, that's why. Confusion, misplacing time, mood shifts, personality changes. Okay. Maybe AI didn't treat me right. Maybe there's less in here. Does anybody have any questions? As I start to figure it out here.
If I would
Yeah.
ask. So how does one judge sort of the normal course of aging and having difficulty coming up with words that you are very familiar with and having to start talking around the words to describe them to somebody to arrive at what you're trying to say versus something more serious? How does that begin to ascertain that?
Well, I would say again, it happens to all of us, right? And the fact that you have that innate skill to say, I know I can't come up with the word Augusta, but I'm going to talk about how to get, if you talk around it. That's actually a skill I would teach somebody who is starting to have trouble with memory loss, is to describe it when you can't think of the word. Again, it would happen if it disrupts your day-to-day life. That's when that's when it would be a concern. But if it's happening quite frequently, I don't think it can hurt to get tested. Doctors are now screening in their offices. I do cognitive testing in my office, which is a little bit more in depth. And again, sometimes that can be a symptom of depression. It could be a vitamin insufficiency. It could be all kinds of things that are causing that one language problem that may or may not be a symptom of dementia. Yeah. So it's more so if it affects your daily life and the frequency of it. If that makes sense.
The spatial thing you mentioned, I find when I'm driving, if I pass that intersection, or is that up ahead of me? Is that normal age?
That's an attention issue. No, really, it is. So when you think about cognition, there's a hierarchy. And first you have to be paying attention. That's what my husband says. If you want to remember something, first you want to remember. But you also have to be attending. So, that happens to the best of us, too. Also, how did I get here? I don't remember going through Wiscasset. Now I'm in Newcastle. That would not be a visual spatial thing, but that is an attention thing, where your body is in space. I'd be more concerned that you didn't see the car stop in front of you, that kind of thing.
Or like when you can't hear your wife.
That's selective hearing. That's a man issue. No, it's not. It's a husband issue, not a man issue. Excuse me for the men who are not doing that out there. Yeah, Larry.
Do all these vitamins they advertise on TV lamb?
No. No, I can't speak for all the vitamins on the market, but if it sounds too good to be true, my guess is it probably is too good to be true. There are medications that, if you know that you have a cognitive impairment, that have been proven to maintain and slow down the progression of dementia, and some patients have noted improvement, whether that's an actual improvement or if it's just that they're getting the other attention they need to improve their quality of life. But yeah, I've been told by other folks who are specialists in it that if it seems too good to be true, it's probably not. It probably is too good to be true. But there are different supplements that do help. CoQ10, I can never say the things, but yeah, CoQ10, that is known to be helpful. And there's other supplements out there that are like that. But not if it's an all-in-one, your brain's going to get better if you take this. Anything else? So I think so writing is another one that's part of the language, which for social activities, yeah, I guess maybe I did it, but. So really, in summary, normal versus abnormal is, yes, everybody has typical episodes of forgetfulness or not remembering names and misplacing things, but it's when it really affects your day-to-day life. Maybe other people are starting to notice, are concerned. And if someone you care about is showing these symptoms and they start to get defensive, depending on their personality, being defensive is also one of the symptoms of Alzheimer's and dementia, and becoming more agitated, more irritable. But again, the most important thing, that's why I wanted to come today when Revan asked me, is the importance of early detection. So if you are concerned, or if you're concerned about someone else, a really quick, easy screen can let you know, yeah, there's some reason for concern. We should probably, keep an eye on it, or, you know what, no, you're fine. So many people come and I'm like, no, you're doing great. You're like, really? Yes, you're fine. Come back next year, we'll check again. But yeah, so overall, that's my message today, is to, if you're concerned, talk to your doctor, and they can do a little screen, and or we can do it for you here, and there's other folks who can also do a little test for you. That's it. Am I good? Okay. Thank you. Sure.
I hear about research that's going on to try to find, I'll say, a cure.
Yeah.
In your knowledge, what's happening?
Oh, I don't know all of that. I know that the Alzheimer's Association is putting a lot of funding towards it, and I don't know what the latest is. I can't say. I do know what I am trying to advocate for is the respite care for the folks who do have it, because there's so many people who, the increase in the number of folks who are going to have it in the next 20 years is going to be mind-blowing, and we just don't have the services and the care available for it. And so in my free time, I'm trying to find resources through the Alzheimer's Association and other things for the respite care for the folks who are caring for these people who don't, I have, again, people who come to my office who are the only care provider. I have this great screen that all they have to do is check all these yes or no's if their loved one has it, and I can flip it over and say, look, this is what you are dealing with. What you're telling me that you have every day, that takes an army to care for, and you're trying to do it for yourself. That's why you're stressed. You can't do this by yourself. And so I think that kind of information and that validation and getting people in the community the support they need is something that we are all going to continue to have to work towards. So I didn't answer your question. But I'm not really sure what's going on there for curing it, but I know there's a lot of research being put into it. But again, I do wonder if that's where it's going versus the medication route. So hopefully that there's someone doing some good research out there.
Our healthcare system is too good, we're living too long.
There's a truth to that. Yeah, we're not just getting pneumonia and, Yeah, you're okay. Yeah.
I'm okay with it.
Yeah, and I think that's where, as a provider, that's what I strive to do too, is quality of life, yeah. And if you're going to live to be 90 or older, we want you to be able to maintain your independence as long as possible. And so that's where all of us therapists come in to try to get that to happen. Thank you.
All right, thank you, Brooks, for jumping in. If you don't know Brooks Betts, thank you. Brooks Betts is, I call him MacGyver. Most of us probably remember MacGyver. He really is jack of all trades. And I was texting him, and he walked through the door, and I'm like, it's magic. So thanks, Brooks, for jumping in and helping us out. So next up, like I said earlier, we have our very own Amanda Millay. She is a nurse. She's a diabetic educator, and she's going to talk about diabetes education. So thanks for joining us. You want it on the stand? You want to hold it? What's your preference?
I can hold it.
Okay.
Thank you. Sure, yeah. Hi, everyone. My name's Amanda. I am one of the diabetes educators. I'm relatively new to the position. I've been here a little over a year, and I just want to go over the importance of diabetes education. All right, so I am a mother of two beautiful babies. That is Wesley and Sophia. I have also a slew of animals of 2 dogs and 4 cats. I'm a registered nurse, and I also have what is called latent autoimmune diabetes in adults. It's treated as type 2 until it can no longer be treated as type 2, and then it's treated as type 1. So I'm not only passionate about diabetes as a career, but I'm also passionate in my life as well. So really, what is diabetes? Diabetes is when your body can no longer use the insulin that your pancreas creates to bring down the blood sugar in your bloodstream. There are two different kinds. Type 1 is when your body doesn't make any insulin at all, and then type 2 is when your body just doesn't use that insulin correctly, whether it's not making enough anymore, or you're become insulin resistant, where the insulin can't bring the sugar into the cell anymore, or your liver just kind of goes crazy and produces more glucose than your body can tolerate. And so this is pretty much what it looks like. Is the sugar in the blood has no difficulty entering the cell with the little key, and enters the cell, and then it comes out of your bloodstream. And then with type 2, that sugar is not able to enter the cell, and so then it builds up in your bloodstream and wreaks havoc. So how is diabetes diagnosed? There are several ways, but the most common is A1C testing, the common test that measures your average blood sugar level over the last 3 months. A high A1C level, higher, may indicate prediabetes or diabetes, and then no fasting is needed, but there are other tests as well. So A1C testing, if you're above 6.5%, that's diabetes. Anywhere from 5.7 to 6.4% is prediabetes, and below 5.7% is a normal A1C. But you can also test by fasting blood sugars. Anywhere over from 126 is considered diabetic, and then 100 to 125 is pre-diabetic, and then normal is below 99. And then the glucose tolerance test isn't typically done. That's when you drink the really yucky drink, and then they test your blood sugar. And then some symptoms of diabetes: fatigue and weakness, itchy skin, thirst, rapid weight loss, excess weight, elevated glucose levels, tingling fingertips, frequent urination, sometimes having slow healing wounds. Definitely is something to look into. If you have any of these symptoms, please reach out to your primary care provider. Some risk factors are people over the age of 40, but that has kind of been changing. We've actually seen diagnoses on younger people in their 20s and 30s of type 2 now. So really, if you're having any of these symptoms, we want you to get checked out, along with high cholesterol, high blood pressure, obesity, and really genetic inheritance. That's a big, they're finding that's a big role player now. And then prevention, healthy eating, exercise, smoking, quitting smoking, glucose control, and then some complications that can come from diabetes is nerve damage, blood vessel damage, eye damage, heart damage, kidney damage. Every kind of damage in your body, unfortunately, can come from diabetes. That's why education is so important. So this is just prevalence of diabetes in our community. So this is just for Lincoln County. And so so diabetes in general, it actually has decreased. The 8.2% is where we were from. That's the percent of the population that has diabetes. So it has decreased compared to the national averages, which are the further numbers. The national is the 10.9%, and the state of Maine is 10.4%. So it has gone down, which is really good. But people who have formal diabetes education is only 65.6% of the diabetes population, which ideally it would be good to have that at 100%. So the cost of having diabetes in Maine is very expensive. Total cost per person with diabetes per year is, I believe it's per year, yes, is $30,000. No, I think that's in a lifetime. But $30,000 for someone ages 19 to 64, and then it's $14,000 for 65 plus. So that's a lot of money that you put into something that either can be not prevented, but it can be well managed. And so there are some programs. So this is a diabetes prevention program. There's one offered at the YMCA and then one offered through MaineHealth. This is if your A1C is between 5.7 and 6.4, you are qualified for this. And this is a really good program to really teach you how to live that healthier lifestyle and to prevent more complications coming and prevent the diabetes diagnosis. And then Diabetes Self-Management Education Services is what we offer here at Lincoln Hospital. So it's very patient-centered. We treat the patient as a whole person. Not only are we supporting them for their medical needs, but also emotional, behavioral, learning needs, anything. We are very patient-centered. We do provide access to more care. We have more flexibility than a primary care provider has. So we're able to get in, answer your questions, maybe manage your medications a little bit in a more timely manner. Advocacy, we speak up for the patients. Some patients may feel intimidated speaking with their providers, and so we can do that for you. Like if you have a medication question or if you're not liking your medication, you can let us know. We can talk with a provider. We can come up with a solution. And then also support. We support in any way, shape, or form that we can, whether medication, testing, emotional support. I say, hey, give me a call. Diabetes isn't fun. If you need to complain, give me a call. I get it. And then how people benefit from the diabetes self-management education. So they see a reduce in their A1C. At least 1%, which is really good. And then that also decreases diabetes-related deaths, cardiac complications, heart failure, all of those things. So even just a 1% reduction in your A1C lowers all of these risks. Blood pressure. So with a reduction in these, in your blood sugar levels, you'll have a reduction in your blood pressure. So that's one way that can be help. Medication adherence, diabetes education has been shown that with the more regular support, there is, you're more likely to take your medications and be adherent to that, which, I mean, if you're feeling better, then you'll want to take your medications, and if your medications are giving you side effects, you're not going to want to take them, so that's how we can support. And then definitely decreasing diabetes complications. Like I said, it does wreak havoc in your body and it affects every single function of your body. So decreasing your blood sugar decreases all the complications. We also really focus on tips for a healthier lifestyle. We go over a basic meal plan, help with working out if that's something that you're looking into, really consistency, enough sleeping, mental health, all of the above, we can really help with that. And then also we can reduce the cost, because when you have a better managed A1C and diabetes, you are going to be spending less on your medical costs. Any questions? Yes.
Part of physical always was a urine test, which tested for diabetes. Now wellness visits, there is not that.
Yeah.
How is it detected unless special blood work is ordered?
That's it. You'll need typically in the office they do a finger stick A1C where they just poke your finger a little bit, get a little blood, and then put it into a machine. If that's not something that they're doing, it might mean that you don't have a high risk for diabetes, but typically once you hit a certain age, they want to monitor it yearly. So that might be something that you would need to ask your primary care provider about. Any other questions?
Can you talk a little bit about the diabetic foot?
Yeah, absolutely.
Don't understand, how does that?
Yeah. So actually, I did forget to mention at the very beginning, I'm also a certified foot care specialist. So I'm able to do diabetes foot checks and things. So how diabetes affects your feet is you think of a sugar granule, and it's very sharp. And so when you have an excess amount of that flowing through your body, it's going to damage those teeny tiny vessels and the teeny tiny nerves. And so when you lose feeling in your feet and you step on a nail, you might not know it. And then you walk on it, and then you continue to walk on it. And then if you get an infected wound on your foot, and then it just escalates from there. So did that answer your question, like how diabetes affects your feet, or?
It stops the nerves.
Yeah. So typically, with someone that has a higher A1C, we make sure that you have better control that can reduce your risk. But really, after a long while, you do lose the feeling in your feet, and that's when it's good to make sure you're monitoring your feet and watching for any sores. Because if you don't know you have a wound, then it will unfortunately progress.
Amanda, great
Yes.
job. Could you speak to the two other services that you're going to be providing up at the Wellness Center?
Yes.
In partnership with the PCP office?
Yes, absolutely. So we are now able to check A1Cs in our office. So if you do find that you're having difficulty getting in to have an A1C check, then we can certainly do that as well. And then we're going to be doing foot care clinic as well. We just got the A-OK. We ordered supplies, so that's very exciting. And then potentially we're going to be able to do diabetes eye exams up there as well. That's kind of in the works. We're trying to figure all of that out, but that'll be available up on the hill as well. Yes.
Any other questions for Amanda? Nice job.
Awesome. Thank you.
Thank you so much. That was fantastic. I have to say, I am always so proud of our care team. This is an example of people with expertise doing their work, but then expanding their work and being very innovative in how they're doing their work and what they're offering. And that is driven by what they want to be doing because they love what they're doing, and it's also supported by their leaders, in this case Kelly Creamer, and just wanting to make sure we're doing the right thing for our community, and it's impressive. So thank you, Amanda. All right, so next up we have Melissa Brown. Melissa, as I said earlier, is our manager of infusion and oncology services on the third floor of the hospital. No, we're not on the third floor. We're on the second floor. We want to be on the third floor. Sorry, I'm in the wrong space already. I want to be on the third floor. And as I said earlier, she's also taken on surgical services as an interim role, which is just huge. So we're excited to have an update on our renovations that are on the third floor.
Hi, Melissa Brown. I am the nurse manager for infusion services at Lincoln Hospital, and I also support the oncology practice here. So I wanted to come to talk to you about our renovation. It's something that has been near and dear to my heart for 6+ years. If anyone of you have come to Lincoln for infusion services, you'll know that prior to 2020, we were in a very small little corner in the day surgery department where we had 2 chairs, and we saw patients in there. But when we brought on oncology services, we knew right away we had to have more space. So we did. We grew to 4 chairs, so a little more space. But we are really excited to keep expanding. We know that we need more space. We don't want to turn anyone away from our community, so this is where this project came from. So I wanted to give you a little background into our current space. We started out as 4 chairs, quickly outgrew the 4 chairs, and now we are up to what I like to call 5.5 chairs. The half chair is really a chair that's not in a great location in the department, so we tend to do quick injections, quick services in that chair. It's definitely not a chair somebody would want to sit in for hours, so that's why we call it 5.5. In the summer months, our volume greatly increases with our summer residents coming back into town. So there are often times in the summer that we utilize OR room 9, and it gives us 2 additional chairs down the hall. So we're very thankful that the OR will let us use that a couple days a week. We staff the department with 4 RNs, one CNA unit secretary a day. We provide services for chemotherapy, immunotherapy, IV infusions, injections, transfusions, and therapeutic phlebotomies. We'll really do any service that is within our scope, so we try really hard to keep patients close to home. Also wanted to talk to you about our oncology practice. So we are currently in 2 separate locations. Infusion is on the 2nd floor of the hospital, and our oncology practice is located in the Watson Health Center. We have 2 exam rooms, 1 oncologist, physician associate, 2 RNs, 2 MAs, and the services that we provide over there are cancer care, hematology, chemotherapy, patient teaching, and they also recently started a cancer support group over there. So we have been in the 2 separate buildings since 2020, which means our oncology providers are going back and forth between the 2 buildings throughout the day. We try really hard to not have this impact our patients, but there are times when they have to go over to Watson and then come over to us, but we really try to limit that as much as we can. So our renovation really started back in 2020 when we opened up our very teeny tiny little infusion center that we have now, but knew we would outgrow it very quickly. So it's been on our minds since 2020, but we officially started in 2025 in June. The project started with the asbestos abatement of the 3rd floor, demolition, and then construction really started in September, October of 2025. And we are looking at about 10 to 12 months and hope to be in the new space mid-September. And I'll show you on my next slide. This is looking down into what our future space will be. It is excluding some areas at the bottom where our new waiting room and check-in and check-out areas are. But to kind of give you an overview of where we're located. If anyone had to go to the hospital for physical therapy prior to physical therapy moving up the hill, this is the location. This red area is the old gym. So it's got the big, beautiful windows that overlook the river. We're going to have lots of great natural light and hopefully a really calming, peaceful place for our patients who can sometimes be having infusions for 6 to 8 hours. So it's a long day for them. So we're really excited to be in the same space. Most cancer care centers are within the same department with steps between each other. More for patient-centered care mostly, but if we have a chemotherapy reaction, we really want those providers close by, and this gives our providers close proximity to the infusion center.
Can you just explain that purple?
Yes, I'm sorry. The purple will be the practice. So purple is practice, and red will be the infusion center. Thanks, Revan. So our new oncology practice will have 5 exam rooms, 3 provider offices, waiting room, a designated check-in and check-out area, and a family teaching room. I don't know if from your view you can really see those 2 pictures, but the top picture is the exam room, and the bottom picture gives you a look into our waiting room, and then over to the left is the check-in and check-out area. This is something for the infusion center. We've not had a designated waiting room, so we're really looking forward to having that space for patients when they're coming in for the day. Our new infusion center will have 8 infusion pods. Each pod will have a heated recliners that elevate for ease of patient access for nurses, space for up to 2 visitors per patient, a TV, and a USB port. Very excited to be able to have space for visitors. For anyone that's been into our current space, there's very limited room for visitors, and that's one of the most important things for not just our oncology patients, but for all patients to be able to have their loved ones with them, especially when it's a lengthy treatment. So this will provide space for 2, which will be wonderful. The pods will also, as you can see a little bit, they're half wall. So the walls will stop pretty much to about here, and then the rest will be glass. This will give the patient, while they're seated in the recliner, privacy, but give the nurse who's standing outside of the pod access to see the patient at all times. So we're looking forward to those private spaces. We have decided to go with a spa-like theme in here to make it as relaxing as possible with blue, green, light green tones, lots of natural light. So it's hopefully going to be a very relaxing space. In addition to our 8 pods, we're also going to have one infusion room, private infusion bay. So this will have a bed, space for up to 2 visitors, and a TV. What we've experienced over the last 5 years is there are occasions when a patient needs to be with us but feels crummy. And a bed is where they're comfortable. So we really wanted to provide a space for that patient population, as well as we've had certain kinds of cancers where it's really uncomfortable to be in a recliner. And so a bed is an optimal location for them to receive their infusions. So some enhancements that the infusion center will have is a new Pyxis with refrigeration, a discrete chemotherapy drop-off area. Our original design had the pharmacist. Another great aspect of our renovation is we will also be on the same floor as a pharmacy, so close proximity to the pharmacy.
Can you explain Pyxis?
Yes. So Pyxis is our medication system. It's essentially a box filled with medications that's only accessible by the pharmacy team and nurses. Our current Pyxis does not have a refrigeration unit with it, which means our pharmacists are having to go back and forth between our unit often throughout the day to provide us with those medications that need to be refrigerated. So this will help decrease foot traffic for the pharmacy team, and also have those medications quickly available for the nursing team. Our original plans for the infusion center had the pharmacy team walking down the main hallway of our new exam rooms and our new oncology practice. But we quickly realized that that's not what's in the best interest for patients, to be coming out of their exam with our oncologist to see we like to call it a lunch box, but our lunch box of hazardous chemo medication going down the hallway. So in order to prevent that, we've created a back door to our medication room, and it's very discreet. The pharmacy team will come in through the back door, drop off those hazardous medications, and then we'll be able to administer them as soon as possible. More enhancements is private patient care area, something that we lack greatly in our current space for visitors, dedicated pharmacist in our department. This is something that we don't currently have, but is something that most cancer care centers throughout MaineHealth have, is a dedicated pharmacist within the department. We're really looking forward to that. She or he, whoever it ends up being, will be able to provide education to our patients one-on-one, and will also be a resource for the nurses. Proximity to our oncology practice, that's one of our biggest wins, is to be so close to our providers and the practice. Dedicated waiting area for infusion patients and our oncology practice patients. We are planning on bringing on cold cap services. It's something we've been interested in for years, but did not have the space for the equipment that's required for that. So for anyone who isn't aware of what a cold cap is, it's an option for patients if they would like to maintain their hair during chemotherapy. It doesn't work all the time, and it only works for certain medications, but it is an option that a lot of patients are interested in. We just haven't been able to offer those services with our limited space. So looking forward to providing that service for our community. Also, a clean supply storage area. Our current storage area is a closet, a teeny tiny little, actually it's not even a closet, it's a cabinet. So we're looking forward to having a big storage area where we don't have to go all over the second floor to find all the needs that we have. So looking forward to that designated area. And that is pretty much it. Would love to answer questions if you have any.
statement. I used to drive people to Portland for treatments, and it was the drive to and from were very, very difficult for people. So this is amazing.
Yeah, we're really excited to be able to provide these services closer to home. It was always unfortunate to think of our patients driving from Pemaquid past our hospital just to go another 30, 40 minutes to get services. So very fortunate to be able to provide that here.
Thank you, Melissa. Excellent job as always. All right, well, just a couple of other updates since we have a few minutes. Most of you are aware that we also have a facility in Waldoboro that we are building. There's a lot of construction happening, isn't there, Brooks? So Waldoboro, the practice there will be primary care, pediatrics, and it is going to be a combined site. There's a Penn Bay practice and a Lincoln practice in Waldoboro in old houses that have been renovated for patient care. We are going to leave those, come together in one beautiful new facility that's being built that should be done in March, and we should be moving in end of March, hopefully be up and running beginning of April, and combining those practices. So it's a wonderful new asset for that community, and that is a large community. It's our largest town in Lincoln County, and it's a growing town. It had sold the most real estate last year and in the state of Maine, in that little population of Lincoln County, Waldoboro, and so they are a growing area, and we want to be able to provide services in that new facility, which is very exciting. And as we saw with this new facility here in Watson that we're in, it'll be a recruitment tool. So providers and care team have been doing a great job providing care in those little houses that have been renovated, but bringing them into a new space and bringing new providers in is an attraction, and we're able to recruit better with that kind of a tool. So that'll also help us with recruitment in rural Maine, where it's not as easy to recruit for some of these providers. So we're also getting ready to, and we've had even a meeting already this morning, another one this afternoon, talking about OR and surgical suite renovations. We're kicking off that renovation project and this month, and that will kick off and be a long process. We're hoping to be done by next January and have that all completely open. The reason we are renovating our ORs, one, they're older OR areas, and the space, we've sort of pieced it together, sort of like what we do here, to make things happen and make things work. But we're finding that as we grow as a community, and as we work together more in what we call the coastal region, so the coastal region for MaineHealth is Waldo Hospital in Belfast, Penn Bay Hospital in Rockland, Lincoln, and then Midcoast Hospital in Brunswick, working more closely together, we're finding that leveraging all of our ORs to provide care is what we need to be doing more of. And Lincoln has the capacity and the ability with this renovation to help serve more of our region and help provide space for our surgeons and for our patients up and down the coast. So that's what we're working on. It's going to be an interesting renovation project. Anytime you renovate something as important as your OR space, it is a challenge. I think we're up for it. The team will have to be up for it as well. The surgeons, everybody, the patients. Hopefully the patients won't experience anything different than they do today, but behind the scenes, a lot of work to continue to do surgeries and do a huge renovation project, but that's coming. And that's really awesome because we're growing. And we're sharing care up and down the coast. We're trying to leverage where we can provide more care and where we have to shift care just because of the changing landscape. So really important work that's happening in our region. And more so really with Lincoln and Midcoast working really closely together with clinical services and trying to decide how do we provide services better for Lincoln County and for the people in the Brunswick catchment area. So that's been a lot of focus and a lot of work. And I would open up to questions or anything the team thinks I should update on as well. John?
Are there any plans as far as emergency room expansion so people don't have to lie down in the hallway because there's no facility?
fabulous question. What Mr. Harris just asked is there any plan for renovation for the ED? We do have a small emergency department. We do at times need to use hallway space for patients on our stretchers, which is unfortunate. We try not to have to do that, but it does happen. Yes, the answer is yes. In fact, for our capital strategic planning process for what we call FY27, which starts in October of 2026. We're just talking about it, was it this morning? Yesterday. We talk about a lot of things. So yesterday we were just talking about that our number one project to get in queue for approval through the MaineHealth system is a renovation project for our emergency room. Whether or not that starts in 27 or 28, we don't know, but we will put that together to put forth in the system along with all the other projects in the system. But that is a very important one. We need to expand the capacity, but we also need to be addressing our behavioral health patients and how we care for behavioral health patients. Today, we have one room that we call our safe room so that we can keep patients safe that are in crisis. It's in the middle of the department. It's not the best spot because then everybody's coming and going around that patient, which is overstimulating usually for patients that are in crisis, and it's just a little bit disruptive. So part of that, we will be planning for specific space that will give our behavioral health patients that are in crisis that need help a little bit more private space, not right in the middle of the department, which will be helpful for everybody. So there's lots of thoughts around how we'll do that. We've had colleagues renovate their emergency departments. Waldo did it probably 6 years ago now and finished it a couple years ago, and Penn Bay just finished their project. So that's one that we're going to put in for Q. Great question. Thank you. Any other questions?
Probably the urgent care itself somewhat.
So the urgent care helps somewhat with volume.
Instead of people going to emergency room, they go to urgent care.
That's a great point. The question is about other levels of care, I think, and so we have varying levels of care available in Lincoln County. I would say, depending upon what your need, obviously if you're in a crisis or having a true emergency, the emergency room is always where we would like you to go. But if you have something, you have maybe a cold-like symptoms or something like that, we'd like you to call your primary care, because if we can get you into your primary care office, maybe you don't see your primary care doc, but you see somebody in their office, that's the best place to have you go, right, for minor things. Or in this building, we have the walk-in clinic, so you can come in and go upstairs to the primary care floor and walk-in clinic. And then we have the urgent care that is down in Booth Bay, and that urgent care is also open. It's a little confusing because really that urgent care in Booth Bay does exactly what the walk-in care does here. It's named differently right now. We're working a plan to make it a true walk-in clinic and shift that a little bit, probably next year. But it's really the same care. The only difference is here in this building, walk-in clinic is billed closer to what you'd get billed for a primary care visit. And down in Booth Bay, because when we transitioned that out of an emergency room to an urgent care, it's under an emergency care classification, and the billing is higher. So the cost out of pocket, the cost of the patient is higher. We're trying to fix that. We think we have a plan. We're working on that plan to make them the same cost structure and sort of align those two. But those are the level of cares available. And yes, ultimately the answer is those help to keep people that don't really need emergency room care out of the emergency room and in those other levels of care. It's a great question. Anything else?
Just like an observation and a patient here. I've used all of those services, and at one time or another, and the walk-in clinic is fantastic.
Oh, fan,
the
good.
ability to address an urgent medical need without having to go through the scheduling process and the difficulty of working with your primary, but yet still have access to that care team is fantastic, and it's really been a benefit.
Thank you. And And that was the point of opening that, is to have it be an adjunct to primary care, because you can't always get into primary care, and that is difficult, so that is an option for people. We also have a little bit different hours of operation, too. It's open on Saturday and Sunday here. Down in Booth Bay in the winter, we will not be open at urgent care on Sundays. We did a whole analysis of our volume down there, and there's a few holidays we'll also be closed down there because we just don't have any volume, and there's no reason to have people there. And we have the option, if somebody did need it, walk-in clinics open here. So we're trying to navigate being really, really efficient and providing access to care as close to home as possible, and encouraging people to use the right level of care. And if we can keep people that just need urgent care or walk-in clinic or primary care out of the emergency department, hopefully we'll have less people in the hallway too. So it's a whole big master plan. Anything else? Great questions and comments. Thank you. As always, a pleasure having you all here. If you have things you're interested in, again, don't hesitate to let me know or let the team know. We want to provide you with information that's helpful and meaningful. And we appreciate each and every one of you. We appreciate that you are advocates for us in the community. Invite your friends. We love to have as many people as possible. And we thank again LCTV for being here, streaming this, and for having it available for others so they can have the same information at a later date. All right, so thank you, and safe travels, and we won't see you, so happy holidays as well.